pertussis today. It's not a new foe, it's an old foe, but fully forgotten in some places, I guess. So here I would like to really, this is my conflict of interest statement, I really would like to emphasize why we shouldn't forget about our pertussis vaccinations. So first of all, let us revisit the causative agent, the Bordetella pertussis. So it's a bacterium which attaches strongly to the cilia of the respiratory epithelial cells, and it secretes many toxins which really inhibit the immune functions and the ciliary clearance of the host and causes dermal necrosis. And it causes inflammation of the respiratory tract and interferes with the secretions. And the very recent data shows us that it's not just the upper respiratory tract, but also the bacteria have been shown in the alveolar macrophages in the lungs. So we know that it's an invasive pathogen that really causes severe lower respiratory infections. It's usually endemic worldwide, but we see peaks every 2 to 5 years. But of course, the COVID-19 pandemic has an effect on the transmission. So we have seen a period where we did not detect pertussis as well as the other viruses. Asymptomatic transmission is possible and affects all ages. But unfortunately, the emphasis of pertussis vaccination have been on the prevention of pertussis among the newborns, among the children, but very little emphasis has been made to prevent pertussis among adults and older people. So actually, tetanus, diphtheria, pertussis, measles, these all have been called as the disease of childhood. But what we have done is to just look at the seropositivity among the routine clinical practice population that we see every day. And here you can see that, please look at the blue bars, 90% of the patients that we have seen in our daily routine practice in the general internal medicine geriatric outpatient clinics were seronegative for pertussis. So they do not have any protection against pertussis. So this means that even more than tetanus and diphtheria, we need to put pressure on vaccinating the adults with Tdap for pertussis as well. So this is the data from UK, a very recent data, and here you can see that the fraction of adults and older people which really have pertussis and notified by the healthcare professionals is increasing. So here you can see that 1/3 of the pertussis cases were from among the 0 to 14 years, another third were among the 15 to 44 years, and the last 1/3 was above 45 years. So it's more than a communicable disease of childhood, it's for sure. And the bad news is that actually these numbers do not really reflect the real world situation, and this is again a very recent data from an Italian cohort. And here you can see that as the age increases, actually the notification rate is just falsely predicted. So I mean, here, look at the data. This is from 2018 and this is from 2019. And when you look at the notification rates and the estimated excess incidence, you can see that nearly 4,000 times higher cases were estimated when compared to the notified dates. And we can really see that this may be true because the seroprevalence study in UK cohort of COPD patients very recently indicated that nearly 6% of the COPD patients have contracted pertussis in the recent year. So this is huge when you just project it to the whole community. And there are many risk factors for pertussis in adults. So some of them are risk factors for contracting pertussis and for having the disease, and some of them are risk factors for having a severe disease. And when you look at these two cohorts of patients with pertussis and without pertussis, you can see that obesity, asthma, type 2 diabetes, and COPD are very important risk factors for pertussis episodes. And especially we need to put emphasis on the chronic lung diseases. And here you can see that the risk of pertussis increased like 5 times among the COPD population, and it increases like 7 times among the asthmatic patients. So these are really important risk factors for contracting pertussis, and also risk factors for having a severe disease. So pertussis is really a diagnostic conundrum in adults, we can say that. And this is an infographic from a recent study made in Korea, in South Korea, and you can see that these patients actually receive diagnosis of acute bronchitis, pneumonia, upper respiratory tract infections, and even allergic rhinitis before and after the diagnosis of pertussis. So it's a very highly misdiagnosis disease in adults. And especially patients over 50 years of age can present with very non-specific symptoms, and these non-specific symptoms usually lead to the misdiagnosis of these patients. And here we can see that patients over 50 years of age, this is a cohort from the UK, have significantly more practitioner visits, they have significantly more accident and emergency visits, more prescriptions, more clinical assessments, and more medical costs. So this starts from the month before 11 months of the diagnosis. So it means that a pertussis patient can just go around without a certain diagnosis of pertussis for nearly 1 year before getting the real diagnosis of pertussis. This is because adult patients usually present with atypical courses and some non-specific symptoms. So this leads to not only late diagnosis, but also a higher and longer infectivity and transmission, of course. So although the symptoms can be variable with age, with the vaccination status, and with the antibiotic use, sometimes people just come up with respiratory symptoms like sinusitis, otitis media, lower respiratory tract infections, but especially in the older population, you can see some very different symptoms like rib fractures due to the paroxysms of cough, like syncope, like falls, urinary incontinence, and even very severe complications like intracranial hemorrhage, encephalopathies, carotid artery dissections, and pneumomediastinum. And here you can see that actually we always think that pertussis is a disease with cough. Yes, that's true. So some of the adults really can present with cough. Here you can see in this cohort at all ages, nearly 40% of the patients present with cough. But when you look at the other admission diagnosis, here you can see that some patients are admitted with COPD exacerbation, some patients are admitted with pneumonia, and even with respiratory failure. So it's always important to keep in mind that pertussis can present with very different clinical conditions and symptoms among the adult population. And here I would like to show you a CT image of a patient with HIV to show you that how pertussis can be a very invasive pathogen, very invasive infection, especially in the immunosuppressed patients. And here you can see a very dramatic consolidation of the lungs. So it is a pathogen that may cause severe lower respiratory infections, pneumonia, and even bacteremia in especially immunosuppressed patients. And it's again a dramatic case I have taken from the literature. Here you can see the rib fractures due to the paroxysmal cough, and even here you can see the fracture. Oh, doesn't move. Here you can see the fracture of the transverse process of the rib just the spine. Thank you. So that these patients really suffer from some very acute and dramatic complications of pertussis. So I think it's for sure that we need to protect our communities, our patients on a lifelong basis for pertussis. So we really do need to put emphasis on a lifelong protection strategy. But unfortunately, the policy among pertussis vaccination has been usually focusing on the prevention of pertussis among the newborns. And the tetanus diphtheria vaccination has been just the focus of tetanus elimination. But when you, for example, look at the WHO recommendations, adult TD prevention and adult pertussis prevention is not there, unfortunately. So actually, we have some solid vaccination recommendations from CDC, ACIP, and we know that for the adults, we now offer 10 yearly boosters of tetanus diphtheria vaccinations. But first of all, the recommendation was issued as the first one should be a Tdap if possible. But this has caused some kind of confusion, because if you're a practitioner and if you stock vaccines, you need to stock TDs and Tdaps. And when the patient, for example, comes to the emergency room for a wound management, then you miss a chance of having that patient vaccinated against pertussis as well. So recently in 2019, CDC issued another recommendation saying that you can use a Tdap every 10 years. So the immunogenicity data and the safety data shows that just utilizing Tdap even for wound management at 5 yearly periods, intervals are safe and immunogenic. So in many countries now, Tdap has replaced TD as adult booster doses. And many of the scientific communities and associations also adopted these recommendations. Here you can see that the GOLD guidelines adopt the CDC recommendations, and they recommend Tdap to the COPD patients who were not vaccinated in adolescence for pertussis. And unfortunately, we do not have an ideal vaccine for preventing pertussis, because for the sake of a lower reactogenicity, as you all know, the whole cell vaccine was changed with the acellular pertussis vaccine. But this has caused an important decrease in the efficacy and the immunogenicity of the pertussis vaccination. So anyways, it's still protective. And here you can see the effectiveness data from a clinical cohort. And this data just shows us that you can prevent at least half of the cases of pertussis by increasing the Tdap coverage among the adults. And if you want to translate it into the immunogenicity data, because there's not so much clinical research on Tdap among adults, but this again a very recent research just showing that as we have told that COPD is a very important risk factor for pertussis, and being an adult over 65 years of age, together with the immunosenescence, is also causing a tendency for severe infection. And a study from the United States showed that nearly 1/4 of the cases of pertussis had COPD. So the question is that, can we really provoke a protective immunogenicity, at least among the COPD population? And this study shows that this is the control group and this is the COPD group. The Tdap vaccine can really confer a good immunological efficiency among the COPD patients as well. So there is an interesting discussion going around vaccination recently. That's the prevention of dementia and Alzheimer's disease. So when you go to the influenza congresses, you can hear this very frequently now. And Tdap is also one of the vaccines which may have an effect on the prevention of dementia. So these are the pleiotropic effects of vaccines. And it's said that the infectious pathogens have some kind of inflammation or degeneration in the neural system, so that if we prevent the infection, can we really prevent the neurodegenerative diseases? And some retrospective cohort studies have some evidence on that. And Tdap vaccination has been shown, of course, we cannot differentiate if it's the TD or the Tdap, but at least it has been shown that we can decrease the risk of dementia by 30% among adults 65 years of age and older. So this is something worth doing research on. And another thing that we need to put emphasis is, of course, preventing the antimicrobial resistance, because macrolide resistance Bordetella pertussis is a problem. It's not a global problem, fortunately, yet, but it's a very big problem in China. And here you can see that in this Chinese cohort of pertussis cases, the macrolide resistant Bordetella pertussis accounted for nearly 90% of the cases. So preventing Bordetella pertussis infection is also very important for the prevention of resistant Bordetella pertussis cases. So this is something to be really promoted among the scientific community. So what's the future for pertussis vaccination? Of course, we need to advocate for lifelong vaccination recommendations and guidelines, not just focusing on one age group, one risk group, but a lifelong vaccination recommendation, and pertussis vaccination should be inside that. We really need to have an active surveillance where we can really delineate the real burden of disease, not just observational cohorts or retrospective cohorts, but active surveillance. And we need to have targets for vaccine coverage rate, because if you don't have the coverage rate targets, then we really do not know how to improve and when to improve the vaccination strategies. We need to have wider access and availability for the Tdap vaccines, because I know that in many of the countries, Tdap is not recommended, it's not reimbursed, it's just recommended for pregnant patients in some of the countries. We need to have some vaccination impact studies in order to see the herd immunity, in order to see the prevention of the complications. And of course, we need to have some innovative vaccines in the pipeline in order to prevent the transmission in the community and also confer a good mucosal immunity. And lastly, I would like to just, as a general information about give an example for an innovative vaccine in this area. And this is the BPZE1 vaccine, which is a next generation pertussis vaccine. So this has been developed by the Institut Pasteur and French National Institute of Health and Medical Research. And this is a live attenuated nasal vaccine. And we have been talking about the COVID-19 and influenza live attenuated vaccines in the morning. And this is another example to just improve the vaccine efficacy by also inducing the mucosal immunity. So 4 clinical trials have been completed in the adults. And here you can see the preliminary data from the phase 2b trial that has been done among the healthy adults aged 18 and 50 years, and it has been very recently published in Lancet. So these people were randomly assigned into 4 blocks to receive the live vaccine followed by a live booster, a live vaccine followed by a placebo, a Tdap followed by a live vaccine, and a Tdap followed by a placebo. So what the researchers have seen is that if you just have the live vaccine here, just on the left-hand side, you can see the results of the live vaccine boosted by, again, the live vaccine. Here you can see that a good immune response, which has been sustained over time. And on the right-hand side, you can see that if you start with Tdap and then give the live vaccine as a booster, as a challenge, you can still have an increase in the immune response, and that can be sustained over a period of time. But it seems that the consistent mucosal secretory IgA response is better with the live attenuated vaccine. And another good thing about this vaccine is that it can really decrease the nasopharyngeal bordetella pertussis colonization. And here you can see that after the challenge with the vaccine, within 28 days, the blue bars are for the Tdap, and the pink bars are for the live attenuated vaccine. The live attenuated vaccine can really decrease the colonization, which can ultimately lead to reduced transmission and diminished epidemic cycles among the communities. So, but for now, the best thing we have in hand is the Tdap vaccine. So what we can do is now just try to integrate it into a lifelong vaccination strategy for all of the people in our communities. Thank you.
Thank you. So we've got one question online, but is there any from the floor? So we have a microphone here. Online, how do you diagnose an acute pertussis whooping cough?
Yeah, so diagnosis is a challenge always, because these patients usually come with chronic cough. And during the acute cough phase, they are usually misdiagnosed, so no one requires a multiplex PCR to do the diagnosis. Culture is a very difficult way to diagnose pertussis. We have now multiplex PCR panels, which also include bordetella pertussis, but they are valuable if you catch the patient within 2 or 3 weeks of cough. But after the patient has a consistent chronic cough, let's say at the 6th week of the disease, the multiplex PCR does not work. So it's very difficult to diagnose in the chronic stage. So what we should really do is to run an active surveillance with a disease definition, so that people who just like the ILI surveillance that we do for influenza and other respiratory viruses, when a patient comes up with acute cough and with some maybe risk factors and symptoms, we really need to go for the PCR diagnosis and do the diagnosis in the acute phase. Otherwise, it's very difficult.
Yep, thank you. And last question, thanks.
Okay, thank you. I'm Christo from Indonesia. So given most of what I heard about maternal immunization for Tdap, yeah, they are just given one dose, but one dose of Tdap. Right? But as we know, most adults, at least in developing countries like us, we don't have vaccination certificates, and we cannot understand whether these patients have been given complete DPT vaccination when they were babies or not. Right? So what do you think? Is it sufficient for them to just get one dose or one dose every year, or every adult has to be given from 3 doses like babies?
Yeah, if the patient cannot confirm with a written record that she has received the primary series completely in childhood, you should start with the primary series for sure, because you can never rely on the verbal communication of the patient if it's not recorded. If the patient does not have a vaccine record saying that the primary series is completed, you should always start with the primary series and then do the booster for Tdap.
Thank you.